Today, we will be just discussing how a patient presents with, that is mainly the clinical features, how to diagnose a malaria case, and how to treat and manage the patient. So I am Dr. Vani, working as Scientist D from the NIMR, that is National Institute of Malaria Research, from the Bangalore field unit. William Osler is one of the greatest physicians, and he said that humanity has but three great enemies. One is fever, famine, and war. And of these, the most greatest, the far most terrible, is fever. So this just a sentence by one of the physicians tells that how bad a fever is. And with respect to malaria, you all know that it is a major communicable disease and is not a disease which has been found recently, not in the 1900s decades or 1800 decades, because even if you look into the old mummies and look for the parasites was demonstrated in one of the oldest mummies. So this clearly tells that that's how old the disease is, and still we are not able to control it. Well, the word malaria is from the Greek word, which means mal area, that is bad air. That was the time when they didn't know the cause of the disease, and that's the term they had given. But now we know that it is basically a disease caused by, it's a protozoan, and it is transmitted by the infected female Anopheles mosquito. I think all of you would have seen this life cycle. So after the biting of the infected mosquito, what happens in the human body as a result of this, how the person reflects or reacts is what the clinical features we'll be looking into. So incubation period, fine. Okay, it is the time interval between the entry of the infectious agent to the onset of the first clinical symptom or the sign with respect to the disease. So it is nothing but the time between a person getting bitten by the mosquito and the number of days where he develops the fever or any other clinical symptom or sign. So usually it varies between 2 to 3 weeks, and it depends on the species. So it is somewhere around 12 days for falciparum, while malaria, Plasmodium malaria, it takes around 28 days. So it depends on which area you're doing the survey and on which disease you are predicting. So it basically runs from 12 to 14 or 18 days or maximum to 40 days also. Coming to the clinical features, the first and more foremost symptoms of malaria will be non-specific. That is, usually a patient can initially present with headache, fatigue, or pain in the abdomen, or slight discomfort, or muscle aches, which is similar almost to any of the viral illnesses. But classically, the patient will develop fever, followed by nausea, vomiting, and little bit of low BP, that is orthostatic hypertension. And actual acute malaria will present classically with fever, malaise, mild anemia, and palpable spleen. That is, there will be pain in the abdomen, or simple to say in the stomach, where the patients will start complaining of pain. And when you palpate it, or if you just press the abdomen, you can feel something hard on your left side. So that is the splenomegaly. And anemia is a common feature in the children or the childhood age group. While spleen enlargement is found in high proportions even in healthy individuals, but in case of endemic areas, if a splenomegaly is there, then it is clearly a case of malaria, and it reflects repeated infections too. Followed by mild hepatomegaly, that is right side, you'll be able to palpate some of the organs, that is the liver. And since hepatomegaly is present, the patient can present with jaundice, that is yellowish discoloration of the eyes or the palm and the soles, which usually resolves by 1 to 3 weeks. So the classical clinical features will be the fever because of the release of the interleukins, followed by chills and rigors, followed by the pain abdomen. So these are some of the common symptoms like headache, fever, fatigue, pain. They can have some back pain depending on the involvement of the organs. Chills and rigors, sweating, dry cough if the lung is involved, then usually the splenic enlargement, and nausea, vomiting. A classic malaria case usually presents with fever. And in the fever, it is so typical that initially they present with something called as cold stage, then the hot stage, and the sweating stage. So what happens in this cold stage, the patient starts feeling intensely cold, because of which he starts shivering. And this may vary from person to person and may last up to 1 hour. After this cold stage, he will start feeling intense heat and he'll have the dry burning skin sensation, maybe with associated with headache, which can last up to hours. After this, they'll start profusely sweating, and the temperature also comes back to normal. So this is the classical way the malaria patient presents with. But currently, because of say initiation of the treatment like paracetamol or any of the antipyretics, the patient may or may not present with these three stages. So these are the manifestations of the severe malaria. So if malaria is not controlled, it can result in cerebral malaria or severe of anemia, and even it can involve the kidneys. That is, a patient can go for renal failure. That is, your kidneys will stop working if there is no improvement with rehydration. Also, it can affect the lungs, called as respiratory distress syndrome, and it can also result in hypoglycemia, hypotension, shock, and in certain cases, they can manifest with bleeding or hemorrhagic gums or any evidences of intravascular coagulation, that is DIC. And if the malaria is not controlled, it can result in CNS involvement and can present with convulsions or seizures. And other conditions like hemoglobinuria, that is, a patient can present with dark urine, brown, black, or red urine because of hemolysis. The urine will appear something dark, and they can present with extreme weakness, also jaundice. So these are some of the severe complications of malaria. So anemia is commonly present, is one of the complications seen among the pregnant women as well as children, where repeated infections among the children can result in anemia, as well as an anemic patient is prone for any of the infections, including malaria. Coming to convulsions, it is more commonly seen in the pediatric age group, that is the children, followed by hypoglycemia is more common among the pregnant and jaundice, while renal failure and hepatomegaly is commonly seen in the adults, non-pregnant people. And edema is pulmonary edema is a feature of pregnant women, or there is one of the complications which you can expect in a mother who is going to malaria. So looking into the pregnancy, what happens affected pregnancy is can directly result in fetal loss, or the newborn who was born would have a low birth weight. So average birth weight is for an Indian baby is around 2.5 kgs. If it is less than 2.5 kgs, we call it as low birth weight. Since the malarial parasites can invade the placenta, it will result in low birth weight. And also it can result in something called as congenital malaria infection. That is nothing but the malaria parasites are demonstrated in the peripheral smear of the newborn from 24 hours to 7 days of life. That is, immediately after newborn, if you just take a heel prick of the baby and check for parasites, and if you find the parasites, then we call it as congenital malaria infection. Similarly, for the mother, if she is infected during her first, second, or third trimester, based on which trimester she is affected, she can develop with mild anemia or can go for hypoglycemia. Hypoglycemia is nothing but the blood sugar levels will decrease in our body, as a result of which we'll be not be able to take proper decisions, or the person can go for unconsciousness. And in the mother, she can also develop pulmonary edema. Other conditions like fetal distress, premature labor, that is, usually mother will deliver at the end of 9 months, but because of this infection, she can deliver early, or it can result in a stillbirth. So all these will have consequences on the newborn baby over a period of time. So what happens in children? If there is repeated infections among the children, they can present with convulsions, they can go for coma, hypoglycemic episodes will be common, metabolic acidosis and severe anemia will be common. As a result, it can affect the development of the child. The normal neurological development can be affected because of malaria. While renal involvement and respiratory involvement is unusual, unlike the adults where it is common, and in general, the children can tolerate the anti-malarial drugs very well and they respond very well with the antibiotics and the treatment. So with this, we'll go for the diagnosis of the disease. So here you can see the life cycle or the parasite life cycle and the various ways where we can determine the parasite. So if you just look at the life cycle within the humans, we can detect the circulating sporocytes with the help of serology, or you can go for antigen detection tests. The best will be the most commonly followed is the microscopy or the blood examination, and certain cases PCR. And these are the tests which we do on the mosquitoes to identify the presence or demonstrate the presence of the parasites. So the simplest and the most common diagnosis will be the patient coming to you from the endemic area. He will come and present you with the complaints of fever, chills, headache, rigor, and on examination, you can find out that the patient will be anemic and there will be organomegaly, or the spleen will be enlarged, for which he will present with pain in abdomen. Following which, you can go for either the microscopic demonstration of the parasites, that is preparing the blood smears, or rapid diagnostic kits. We also have other serological tests like immunofluorescence antibody testing, or the molecular level, we have the polymerase chain reaction, that is the PCR diagnostic methods. So these are the list of various diagnostic methods, how to do it, and their advantages as well as disadvantages. The most commonly followed is the thick and thin blood film preparation, where the sensitivity is high, but it needs a lot of expertise of the people to identify the parasites as well as go for parasitic density rate counting. Then is the rapid diagnostic kits, which is based on either the HRP2 protein or the LDH dipstick or the rapid diagnostic kits, which is easy to use it and easy to interpret it, which can be used even for a layman person. We don't need a technician or a big head to understand or do this procedure. While we have other QBC, that is quantiferon buffer tests, as well as PCR test, which has more sensitivity in picking out the cases. So coming to the blood smear examination, first and foremost, we just take it either through the capillary blood or through the venous sampling. So initially, what do? We just clean the slides and select the finger puncture, that is usually the middle of the ring finger. In case of infants, we puncture the heel. And once you, initially before puncturing, please clean the fingers with 70% alcohol, then puncture the ball of the finger. After that, first drop you need to wipe out and then take the next drops on the slide. So initially it will be at least 2 thick and 2 thin smears is what we needed. And it has to be properly labeled and allowed to dry. And that is for capillary. This is for venous blood sampling, that is by the venipuncture. So once you take the blood, there is a specific technique to prepare the thin film. So it is at a certain degrees of angle which you have to just push it and you will have a thin film, and it should be something like you should be able to read the newsprint. And once you are done, you have to fix only the thin film with the methanol. After fixing, you have to stain. Well, there are a lot of stains to stain the malaria blood films that gyms are staining, Freights, Leishmans, JSP, Bhattacharya, and all those things. The most commonly used are the gyms are staining, where you have two methods, that is the rapid as well as the slow method. The rapid method, you need a higher concentration, that is around 10% of gyms are stain, and by the time 8 to 10 minutes, you can just have the readings. While the slow method contains lesser amount of gymsastain, while it takes at least 1 hour to go for the reading. After this staining, we'll observe under the microscope. So slide microscopy for malaria is the standard diagnostic tool, and the results will be made available within 24 hours under the National Vector-Borne Disease Control Program. And the thick film is to just detect whether the parasite is there in the blood film, while preliminary identification or parasite counting, for definitive identification, thin film is the best. So what do you see in this blood smears? So if you look at P. falciparum, that is Plasmodium falciparum, usually the RBCs are not enlarged. You can see something called like ring stage, or this acoliform. That is, you can just see something like a transparent circle. This is within the RBC, that is the trophozoites, and there is some kind of vacuole, and there is a nucleus in that. So this is called as a coliform, and usually you can see multiple infections in, that is in one RBC, multiple trophozoites can be present. And usually this RBCs will remain of the same size in case of Plasmodium falciparum. And this slide depicts about the gametocytes, where the it is almost like a sickle banana shaped. Similarly, the vivax, the trophocytes, here you can see is trophocytes, but just observe the RBCs are sometimes enlarged, and you can see all the stages in the peripheral blood, which is unlikely in the falciparum case. So you can see trophocytes, scisons, gametocytes also in one slide itself. So this is the gametocytes. Okay. And this is about the Plasmodium malariae also, where RBCs will be usually normal or reduced in size, and the trophozoites usually present in the band forms. This is the typical band form which we see. And here also we'll see all the stages in the peripheral blood. This is ovale infection. Usually the RBCs, infected RBCs, the edges will appear fimbriated, and the size is slightly enlarged. The RBCs will swell up compared to other non-infected RBCs. And here you can see the coarse dots, which is called as James dots. So that is about the microscopic test, followed by the rapid diagnostic test, or the RDT kits, what we usually say. So it is usually used in the peripheral health centers or the health facilities where there is need for emergency diagnosis followed by immediate treatment. In case of severe complicated malarias, or in case of cerebral malaria where the patient presents with unconsciousness, so to get the quick result and to start immediately the treatment, we can use this RDT kits. So this is in the absence of lab technician, so you do not have to wait for the technician to come and do the tests. So basically it is based on the antibody, where the capturing dye-labeled antibodies are bound to specific parasite antigens. And commonly used antigens for P. vivax is LDH, that is lactate dehydrogenase, and HRP, that is histidine-rich protein 2 for the P. falciparum. So in the market, you have a lot of kits which are available, that is Bioline, Malarigen, and all those things. So the basic principle here, what you need to understand is, all these are the wells which is coated with the antibodies. And here you will have a place where you put the patient's blood, the drop, or just with after puncturing with the lancet, you can collect 1 or 2 drops here, and you'll add the buffer here, and you will see the lines. So what are these lines? It can be control, antimalarial antibody of all species or falciparum. Here you can see it is control, PV for Vivax, PF for falciparum. So once you add the blood and the buffer solution, you will have to wait for some time, for which within 10 minutes you have to read the RDT kits and you will see the lines, the bands. So what does it say? So definitely there should be one line in the C. C stands for control. So in this, it should be positive. Afterwards, if you see one more line, either in the PF or the PV, based on that, we'll classify whether the patient is having or suffering from Plasmodium falciparum infection, or is it from Vivax, or both, or nil. But please remember, if you don't see any line in the control level, please discard that kit because it is invalid. So can just anyone interpret the results, what is seen here? Just volunteer yourself. Anyone, please?
Third one, please.
Yes. Can you please tell me the results of this? Can you just interpret it? Can you hear me? Yes, please. You can see a line in. You can see a line here. Is it visible? Okay. So here you can just make out that in C, the controls everywhere, the band is seen. Here you can see for PV alone. So this is a case of Plasmodium vivax infection. Here you can see the bands in PF. Please note it can be dark like this or a lighter one like this. So, and also darker like. So depending on the intensity, it is not divided. It is the, at least even if you see a faint line, then you can label it as positive. And immediately you can start with the treatment. So the same thing, if both lines are there, we can interpret as PV as well as falciparum as well as Vivax, and we need to start appropriate treatment. And if the patient is having complaints, and if still the RDT is showing negative, you can repeat the test as well as go for microscopic testing also. So basically, as such, malaria patients are rarely symptomatic at lower densities. And if it is a suspected malaria patient, if he has having RDT negative, then we can assume that he does not have malaria. And at least, like in most of the cases, at least the parasite density should be above 200 per microliters for the RDT to pick up the malaria case. So one thing we need to remember, that is the HRP2 antigen, it can be positive till 4 weeks. So you have to use the RDT kits only for diagnosis and not for follow-up patients. So if you're looking for follow-up, microscopy will be a better instrument to identify the parasite load or the parasite density, and based on that we can say whether the patient is improving or not. But if you repeat the RDT test, once again you'll be getting positive and you will falsely label the person as infected and go for increased or inappropriate treatment. Okay, next is the PCR. PCR is also one of the diagnostic methods which is recently seen, which is mainly because of the sensitivity as well as specificity, and which has high sensitivity and specificity to identify or pick up and separate the species. And the good thing about is it is able to detect the low level of parasitemia in the asymptomatic people, especially in the endemic areas. So this concept of picking up the low density infection is very much essential for us where we are in the elimination phase. But it has its own pros and cons of we need an instrument for that, a trained technician to run this instrument, and the way to interpret and analyze it also. And it is a costly affair too. Coming to the management, the treatment part. So these are the drugs which we usually use for the malaria cases. So you can just see the labeled ones on specific dates, which are the things which we use it. So based on the life cycle, we have drugs which act at different levels. That is, we have the drugs which act as tissue seizonticides, or the gametocytes, or the sporozoites. Sorry, seizones as well as gametocytes. So here you can see that the primaquine is a drug which acts both at the hypnozoid level as well as at the gametocidal level. And we have certain drugs like ACT, that is artemisinin, samidoquine, the chloroquine, which acts as mainly gametocidal, and also to certain extent act on the seizones also. So here is the whole list of drugs which we use for anti-malarial drugs used for malaria treatment. Their common toxicities, which has been listed here. You need to know all this, at least the most common, before starting any of this treatment. That is, like say, chloroquine is commonly used drug for Vivax, but it can cause QT prolongation. So you need to be careful before initiating the treatment. All these are the other drugs commonly used. Atovaquone, chloroquine, yes. This is the prophylaxis of malaria. Okay. There are certain recommendations. The general rules we need to follow is, first of all, do not start any of these anti-malarial drugs on an empty stomach. The patient should have he should have eaten something, because most of these drugs can induce vomiting, or if the patient vomits after giving you the drugs on the empty stomach, it will be a loss, and once again the patient has to repeat the treatment. Suppose the patient has vomiting within half an hour of initiation of treatment, he has to repeat the dose. And just ask the patient if he is feeling better after taking the treatment. If there is no improvement even after 2 days, or if the patient is going for severe malaria, then we need to change the treatment. And he should also be examined and investigated for other illness, and also look in for progression to severity of the malaria. So the clinical diagnosis, as per the NVDCP program, you suspect the patient clinically, prepare the slide. Based on that Vivax or falciparum, you will start with the treatment. Similarly, if the patient is diagnosed with RDT, if RDT is positive for Plasmodium falciparum, we'll start with ACT, that is artemisinin combination therapy, along with primaquine on day 2. And if it is for PV, based on that, appropriate treatment will be started. But for the northeastern states, we'll go for ACT plus AL, that is artemisinin component along with lumefantrine. So based on the diagnosis, it is for Plasmodium vivax, we'll start with chloroquine 3 days, which is a split. That is 25 milligrams per kg body weight is the required dose, which is split on 10, 10 and 5 on day 1, day 2, day 3, followed by primaquine, which is given daily for 14 days. So here the problem is, what we are seeing, or the program officers are observing, is the compliance for such a long days. That is 2 weeks the patient has to take this primaquine tablet, which is very much difficult, and it has its own side effects in certain cases like G6PD patients. So for which the patient failed to complete the treatment, as a result of which the P-Vivax is known for its repeated infection or recurrence because of the hypnozoitic stage. Coming to the P. falciparum, in the northeastern states, the drug combination is artemisinin-based combination therapy along with artemether and lumefantrine is the drug of choice. While in other states, it is ACT with SP, that is sulfadoxine with primaquine. Sorry, sulfadoxine with pyrimethamine, as well as primaquine on only single day, that is second day, we'll be giving the infection. What to do if the patient is having both the infections, that is Vivax as well as falciparum, we need to go as ACT with SP or based on the place where is there, that is for falciparum, whatever we treat, along with primaquine for 14 days, that is for PV. And if it is negative, look for any other disease or repeat the tests once again if you are strongly suspecting clinically. So this is the age-wise dosage for the Plasmodium vivax. Please note the primaquine is contraindicated in case of infants, and it has to be given with caution in case of pregnant women and G6PD deficiency people. So this is once again with respect to P. falciparum. You will give AS plus SP, that is artesunate, plus sulfadoxine and pyrimethamine based on the age or the weight. First day, second day, along with second day we'll giving primaquine, and third day which is just only artesunate drug. So it is just 3 days treatment for falciparum, while 3 plus 14 or 11 for totally 14 days for P. vivax. And all these drugs are color coded so that it can be easily given by the people working in the malaria clinic. Coming to malaria in pregnancy, you just need to remember that we cannot start ACT during the first trimester. In the first trimester, that is first 3 months of pregnancy, we should not give artesunate-based combination treatments, that is ACT treatment. The drug of choice is quinine. It is 10 milligrams per kg body weight for 7 days. And the most common side effect of quinine is the patient can go for hypoglycemia. That is, the blood sugar levels may drop down, as a result of which they'll have certain consequences which can affect the growing fetus or the baby. So as a result, you should always ask the mother to eat something, eat regularly, and then only take the treatment. Well, in the second and third trimester, we can give ACT as per the dosage. And if it is a case of mixed infection, it is the same with primaquine, but primaquine should be watched and given. If they develop any of the complications, that is hematuria and all those things, we need to watch out for and immediately stop the treatment. After giving the treatment, we need to ensure that the patient is cured. How will we know whether they are cured or not? Basically, they should not have any symptoms. That is, they should not have any fever. Or when we go for blood examination, they should not have any parasitemia till the day 28. Most of the patients do get cured. They do respond to the treatment, and provided the compliance is there. But some patients do not respond to the treatment and can result in drug resistance or treatment failure, which is commonly seen in falciparum infection. And recently there are evidences that even Vivax is showing resistance. And if the patient does not respond or presents with the following, we have to switch or change the treatment plan. If the patient is not improving, we have something called as early treatment failure, late treatment failure, and late parasitological failure. So what is this early treatment failure? After starting treatment, the patient's parasite load will reduce drastically and he will start improving by symptoms. That is, if the patient is presenting with fever, his fever will come down. If the pain abdomen is there, that will reduce. So within a day to 1 to 3, all their symptoms will reduce. But if the patient's presents with the danger signs, or if they're going for severe malaria case in the first 3 days of treatment, or if there is presence of the parasite load in the microscopic blood examination, then we can predict the patient is going for failure. If the parasite load is higher on day 2 compared the day 0, that is before the starting treatment, the patient has certain load, and even after treatment, if the parasitemia load is high or may or may not have the axillary temperature, that is presenting with fever, then we'll consider it as a early treatment failure. So please remember, you have diagnosed a patient with malaria. You will start the treatment, and within 3 days, if the patient does not improve or his conditions worsen, then you have to make a guess of early treatment failure. Similarly, if the patient presents with danger signs of severe malaria in the presence of parastemia on day 4 or any day between day 4 and day 28, in patients who were not previously met any of the criteria of early treatment failure. That is, first 3 days they were fine, they were improving. But day 4, day 5, once again, they'll present with fever, they'll go for hypoglycemia, they can present with convulsions. Then you need to think of late clinical failure. This is between day 4 as well as day 28. Then late parasitological failure. That is, if the parasites are present somewhere between day 7 and day 28, along with the mild axillary temperature of 37.5 degrees centigrade, who has not previously met the criteria of early or late treatment failure. That is, first 7 days will be absolutely fine. Afterwards, when you check for the blood smear examination, their slide level may show for the presence of parasites, or they may have some uh, complaints like fever, mild fever. In that case, we need to understand that whatever the treatment we are giving is not working on the patient. So we need to switch the drugs, that is, change for or go for an alternative treatment. If phase 3 is there, go for quinine and doxycycline, like that. But there are certain contraindications for doxycycline. And treatment failure for chloroquine in PIVAX, it's recently seen. We are seeing a lot of failures. So basically, it tells about the development of the drug resistance. So in case of severe malaria, how do we manage it? Usually, for the normal or the acute malaria, we'll start with the oral drugs. If the patient is not able to tolerate the oral drugs, or if his conditions is worsening, then we need to start with the IV antimalarials, antipyretics, anticonvulsants, and all those things, for which we need a specialized training, the health staff, as well as the institutions which provide all these facilities. In fact, for oxygen administration and dialysis facility also. Okay, we have a concept of chemoprophylaxis. That is, usually those people who are traveling to a very highly endemic area, we can start their treatment or give some drugs so that they will not catch up with malaria. So it is usually given for travelers, migrant laborers, or military personnel who are usually exposed to malaria in the highly endemic areas. And along with the chemoprophylaxis, they need to follow the personal protection measures like the bed nets and mosquito coils or their personal protection measures to protect themselves. So if the patients, or sorry, if the people are going for traveling for less than 6 weeks, they can start the doxycycline drug, that is tablet 100 milligrams daily, and it should be starting 2 days before travel. Suppose if I'm going to Africa on Sunday, on Friday I'll start taking the doxycycline tablet, and I'll continue for 4 weeks after leaving the malarious area. If I will come back from Africa, after that 1 week, 1 month daily, I have to take this tablet, provided it is contraindicated in pregnant and lactating mothers and pediatric age group children of less than 8 years. If we are planning to go for more than 6 weeks, then the drug of choice will be mefloquine. That is, we will take mefloquine based on the kg body weight weekly, and it should be administered 2 weeks before, during the stay in Africa, and 4 weeks after leaving the area. 2 weeks before, during that, and 4 weeks, it is a weekly once tablet. Well, it also has contraindications in case of convulsions or neuropsychiatric problems and cardiac conditions. Fine. To summarize, we know that malaria is an age-old disease. The common clinical features what a patient presents with is fever, followed by pain abdomen, fever with chills and rigor, and pain abdomen, followed by, depending on the severity of the case, And usually it is picked up or diagnosed through microscopic examination or the rapid diagnostic test. And we need to understand there is adequate treatment which is available. And after taking the treatment, the complete cure is possible. But basically, it depends on the compliance, the drug compliance of the patient. If there is no compliance, will indirectly result in drug-resistant malaria. Fine. So just to conclude, it was one of the statements made that everything about malaria is so molded and altered by the local conditions that it becomes 1,000 different disease and epidemiological puzzles. Like chess, it is played with few pieces, but it is capable of infinite variety of situations. So it is just to tell that it looks like malaria is just a protozoa, but still there are so many other factors which will influence the disease, and it just goes for an epidemiological puzzle. So that is the complexity of malaria. We need to understand, identify the disease, diagnose the disease, and treat it appropriately to help us achieve in the malaria elimination phase. Thank you.